Hello all, welcome to this massive open online course on oral biopsies. In this module, we will be learning about the various types of biopsies which can be performed in oral cavity. So, before we start, we can understand biopsies can be classified according to the techniques used, the material employed, clinical timing, location or the target of the lesion, or processing of the sampling, how the sampling is processed, or by the purpose of the biopsy. First, we'll learn the technique used for performing biopsies. So, depending on the technique, biopsies can be either classified as excisional biopsies, wherein the whole tissue is removed. Next, it can be incisional biopsy, a fine needle aspiration cytology or a biopsy, then punch biopsy, a scrape biopsy, a brush biopsy, imprint biopsy, and fluid biopsies. An excisional biopsy. An excisional biopsy involves complete removal of the lesion or a tumor, including a margin of healthy tissue with intent of both diagnosis and treatment. So, what are the indications for excisional biopsy? It is basically used when the lesion is small and localized and the suspicion of malignancy is very low. It is also employed for removal of a growth like a polyp. So the basic principle here is to completely remove a small lesion which is usually less than 1 centimeter. Along with it, you remove 2 to 3 millimeter of normal appearing tissue surrounding the lesion is excised. Usually the lesion is removed in an elliptical fashion. An incisional biopsy is a biopsy that samples only a particular portion or a representative part of a lesion. If a lesion is large or has different characteristics in various locations, more than one area need to be sampled. So, what are the indications for incisional biopsy? If the size is too large, and the size is a limitation, so we need to do an incisional biopsy before we need to arrive at a diagnosis. Only then we can go ahead with further treatment procedure. Next, if we have a great suspicion on malignancy, then also we require to do an incisional biopsy. So, how an incisional biopsy is performed? Usually, as you can see in the diagram, the incisional biopsy is performed with sufficient depth. So, the lesion is cut in an elliptical fashion and it is usually undesirable to keep it broad and shallow. So, remember to include the normal areas along with the lesional area and also to administer local anesthesia around the lesion and not in the area of interest. And also, when the suturing is done, it has to approximate the surrounding areas properly so that healing is better. So, an elliptical lesion is usually preferred. So, always remember the excisional biopsy lesions. The lesion is the depth of lesion is more deeper compared to an incisional biopsy, and wherein the lesional depth may end within the lesion only. Next is what we understand is fine needle aspiration cytology or fine needle aspiration biopsy. An aspirational biopsy is done with use of a needle and a syringe to penetrate inside the lesion to see what it has within it. So, what are the indications for aspiration? So, first is to determine whether the lesion has any fluid in it or not. Next, to ascertain the type of fluid within the lesion. It also is used to explore any intraosseous lesion if it is indicated. A 18 gauge needle, which is a wide bore needle of 5 to 10 ml syringe, is usually inserted in the area under investigation after demonstrating anesthesia. The syringe is aspirated and the needle is redirected if necessary to gather the aspirate. If there is inability to aspirate the fluid or air, it indicates the lesion is solid. So, what is the difference between an aspiration biopsy and an aspirational cytology? If an aspirate of the cells is obtained using a fine needle that is 21 to 25 gauge, the technique is usually called as a fine needle aspiration cytology or simply FNA or a fine needle aspiration. Whereas if the core of the tissue is produced using a larger bore of needle like a 14 or 18 gauge needle, the procedure is best referred to as a fine needle cutting biopsy or FNCB. So we have a special type of fine needle cutting biopsy, that is a true cut biopsy. Here, as you can see in the picture, there is this special needle with a sheet around it, and this is inserted. The needle is initially inserted, the inner core enters into the lesion, and then the outer core, the sheet, cuts the tissue, and the particular area of the tissue is sampled and withdrawn outside, and when it's come out, it is used for processing. So aspiration are of different types. It can be air, say if you're aspirating a maxillary sinus, so it suggests that you are in a maxillary sinus. If aspiration of the air is seen in a mandibular cystic lesion, it definitely suggests it is a solitary or a hemorrhagic bone cyst. Or suppose an aspiration is a blood, it suggests that it is an hemangioma, a hematoma, or you are entered into a blood vessel. So aspiration of pus, it indicates it's an abscess or an infected cyst. Aspiration of keratin, that looks like pus, but it has a very unpleasant odor. It indicates it's an odontogenic keratocyst. And if the aspirate is of a straw colored fluid and contains crystals of cholesterol, so definitely it indicates a radicular cyst. The next technique of biopsy is what we call as the cell block technique. Basically, this is a modification of the aspirate technique wherein the aspirate is taken out and later on it's centrifuged and a cell pellet is made. The cell pellet is processed further with a paraffin embedded block, and this block is sectioned and can be reused. So this is a different technique where aspiration and tissue processing techniques are being used. Next, we learn about a new technique, what we call it as a punch biopsy. This is a very easier or a simpler technique wherein a biopsy is performed using a hand instrument, what we call it as a punch. It is used to cut the tissue and a disc is formed, and this disc of tissue is removed out from the remaining lesional area. So basically the technique involves usage of a punch. There is different size of types of punch which are available. The punch is put on the area of the lesion and it is marked, or here it is clearly visible. Next, with the help of a tissue folding forceps, the biopsy is pulled out and releasing incision will remove the lesion. So the next technique is what we call as the exfoliative cytology. The exfoliative cytology is typically used as an adjunct to and not as a substitute for incisional or excisional biopsy. The technique is very simple, very quick, and painless and even bloodless procedure. An instrument like a spatula, a metal or a wooden spatula is used to scrape off the superficial skin or the mucosal area where the lesion is present. So it definitely helps to check against false negative biopsies, and it is helpful in follow-up detection of recurrent carcinomas in previously treated cases. It is also valuable as a screening adjunct or screening of the lesions whose gross appearance is such that the biopsy is warranted. So next technique is what we call it as a brush biopsy or a brush cytology. Here, a miniature bottle brush or a circular brush is used, and the technique is very similar to what an exfoliative cytology is. Instead of a spatula, here the brush is used to perform the cytology or the biopsy. This was first introduced in 1999 as an alternative to the exfoliative cytology, and it is used in investigation of persistent epithelial lesions not considered suspicious for carcinomas. A special circular brush can be also used, and it is used classically in the mucosal biopsies and less invasive than the incisional biopsies. So the next technique is again a variation of the brush biopsy, which is classically known as the oral CDX brush or the oral CDX kit. Here, a brush biopsy instrument is provided along with a glass slide and the requisition form. An alcohol fixative pouch is also given, and this is after you do the cytological procedures, you just mail the slide in the pre-addressed container, and the report is generated from the center of the oral CDX. Next technique is what we call it as the shave biopsy. Here it is again very similar to what exfoliative cytology is, but here instead of using an instrument, a blunt instrument, a sharp instrument like a scalpel or a blade is used to perform this biopsy. This is very commonly used in skin lesions. Next is what we know as the imprint biopsies. The imprint biopsies basically involve pressing a glass slide or a piece of paper on the cut surface of the lesion and collecting the cells or the tissues or the material from the lesion and staining it for examination. So in an imprint biopsy, it is indicated where it is used for intraoperative assessment to guide immediate surgical decisions and to evaluate the lesions with surface changes. Next technique is what we call it as the liquid biopsies. Liquid biopsies are basically the in thing in this current scenario, wherein salivary biopsies are also a part of the technique of liquid biopsies. Liquid biopsies involve analysis of biomarkers such as DNA, RNA, proteins, and other body fluids such as saliva and blood. In oral pathology, in salivary biopsies can provide valuable information in oral lesions and systematic conditions. So these are the various procedures, various techniques which can be used, various fluids which can be used. In the CSF, fluid is used for central nervous system cases. Saliva can be used for head and neck lesion cases, and pleural effusions for the respiratory tract, and the urine for the urinary tract. So liquid biopsies are non-invasive and are increasingly used for early detection and monitoring of oral cancer, systemic diseases, and biomarkers in saliva to aid in diagnosis and prognosis. Next, we talk about the materials employed for biopsies. Depending on the material used, biopsies can be classified as conventional scalpel biopsies, punch biopsies, P4 biopsies, electroscalpel biopsies, and carbon dioxide laser biopsies. A conventional biopsy is usually performed by using a scalpel or a BP blade number 15, number 11, or number 12. A punch biopsy is performed using various diameter of the punch. So it is all color coded. It can be starting from white to a pink color biopsy, a punch biopsy instrument. A B-force biopsy is a specialized equipment wherein it isolates the area to be biopsied by using this clamp, which is a Chalasian clamp, and it is performed in an easier manner compared to a normal incisional biopsy. An electroscalpel is one in which a cautery equipment with a handpiece is given, and with this use of the electroscalpel, electrocautery is done. A carbon dioxide laser scalpel is also similar to what electroscalpel surgeries are, and is definitely easier compared to the normal scalpel biopsies. In a carbon dioxide laser scalpel, the area is marked and then the tissue is completely excised. Here you can notice that because of the use of the scalpel laser, the bleeding is usually limited. Next, depending on the clinical timing of the biopsy being performed, it can be classified as further as a preoperative biopsy, a biopsy which is done intraoperatively, and biopsies of post-operative timing. So, what are these preoperative biopsies? A biopsy which is done after the index biopsy and before the surgery is what we call it as the preoperative window. Any biopsies performed during a preoperative window is a preoperative biopsy. So here it can be one or even multiple depending on the requirement of the surgeon. So what is intraoperative biopsy? Intraoperative biopsies are basically frozen tissue sectioning techniques which is done during the operation, and the result can be received within the operating room in a short period of time, thus allowing the surgeon to continue with the operation if required. So this procedure is indicated when a malignant tumor is suspected, and a surgery can be planned according to the histological findings of the intraoperative biopsies. So here, as you can see, the surgeon is excising the lesion, and the tissue is immediately frozen, and the surgeon can view under the microscope, and further he can also interact with the surgeons in elsewhere and through internet, and can confirm the diagnosis, and the surgeon can be told whether the margins are clear or not. Next is what we call it as the post-operative biopsy. This is done after the surgery is completed, and this is usually done in a doubt where the margins are, the surgeon is suspecting the margins are not clear, and maybe to do a second surgery before that the surgeon is requiring this post-operative biopsies. Next, biopsies can be classified according to the location of the sample. So, a biopsy of salivary gland is a separate entity. Again, biopsies within the bone or biopsies of the lymph node or other head and neck tissue is biopsied in a different technique. So next is what we call it as a bone marrow biopsy. A bone marrow biopsy is examination which refers to pathological analysis of samples of the bone marrow obtained from a bone marrow biopsy, often called as a trifine biopsy, and a bone marrow aspiration. So how does this done? While much of the information can be gleaned by testing the blood itself, which is drawn from a vein, but it's sometimes necessary to examine the source of the blood cells in the bone marrow to obtain more information about hematopoiesis, and this is the role of bone marrow aspiration and biopsy. So what is a trephine? A trephination is a creation of a surgical passage in the cortical plate of the region of the root apex, usually by a burr, to provide a channel to escape of the pus and blood to relieve the accumulated pressure of the jaw around the root apex. So it is advocated in cases of acute alveolar abscess, as you can see in this diagram. So depending on the processing of the sample, biopsies can be classified further as frozen biopsies and embedded biopsies. A frozen biopsy technique, as we had already seen, a cryostat is used in intraoperative procedures, and it allows a rapid histological diagnosis and the sample material processed without any fixation and is frozen by using dry ice. So this is how a dry ice biopsy sample in a frozen section will look like, and the freezing of the temperature is around -40 degrees to -60 degrees Celsius, and it produces tissue consistency that allows sectioning with using of the specialized microtome. Next is embedding technique, wherein we can have two techniques. One is the paraffin embedded procedure, wherein this is the standard procedure. 90 to 95% of all cases are done using this paraffin embedded tissue sectioning. Next is methacrylate embedded tissue sectioning. Here, instead of paraffin wax, resin material is used to embed the tissue. Next, depending on the purpose of the biopsy, biopsies can be classified further into diagnostic biopsies and experimental biopsies. So what are diagnostic biopsies? And diagnostic biopsies are basically one which are used for diagnosing a case or a disease, whereas an experimental biopsy is done on purpose after obtaining an ethical clearance and obtaining the patient consent. It is done for some purpose of experimentation. So to summarize, you have various biopsies can be classified, and each biopsy has its own techniques or advantages and is chosen based on special clinical scenario, the nature of the lesion, and the purpose of the biopsy, whether it is diagnostic, whether it is treatmental, or it is both. So an accurate biopsy technique are critical for oral pathology because they provide tissue sample necessary for definitive diagnosis and guide appropriate treatment decision. So these are my references. You can use these references for further informations. Thank you for your patient listening.